everyone. Welcome back to Endo Bites, where we unpack endocrine topics in short, focused conversations designed to help our primary care providers, advanced practice providers, and learners of all kinds. I'm Srividya Kidambi, Professor of Medicine at the Division of Endocrinology and Molecular Medicine and Chief of the Division at the Medical College of Wisconsin. So as followers of this podcast, you know that we started with bone health and we talked about calcium, phosphorus, and vitamin D. So today we are going to extend our previous conversation on osteoporosis. It's one of the most common and undertreated chronic conditions in medicine. And our goal is to help you understand how to recognize who's at risk for osteoporosis, how to diagnose, and how to treat them in next several episodes. Joining me again is Dr. Joseph Shaker, Professor of Medicine here at the Medical College of Wisconsin and a national expert in metabolic bone disease. I'm so glad to have him back to talk us through the nuances of diagnosis and risk assessment. In our first episode, we're going to talk about the screening for osteoporosis. Dr. Shaker, welcome.
Thanks, Vidya. I'm excited to be here. This is a topic that I'm passionate about, and of course, you know, there's a lot to cover.
Yeah. So we'll start with the basic definitions. So what is osteoporosis, and how is it different from osteopenia?
So let me start with osteopenia, or low bone density. It's primarily a densitometric diagnosis when the T-score, the standard deviations from young adult white women, is between -1 and -2.49. Osteoporosis is defined densitometrically as a T-score below -2.5, assuming the patient doesn't have another metabolic bone disease, for example, osteomalacia. Osteoporosis can also be defined as the presence of an osteoporotic fracture, for example, hip or a spinal compression fracture. More controversial is the combination of low bone density, but not as low as -2.5, with a high fracture risk on a risk calculator. I would actually consider that osteoporosis, but it's not universally accepted.
Okay. There is patients always confuse between osteoporosis, osteoarthritis, and I know our listeners probably not, but I think could you kind of explain how you tell your patients so our listeners can take that to their clinics as to when patients say, I have so much pain, so what do you?
Great question. So I explain that what they have is arthritis in their joints. Arthritis is a joint condition. Osteoporosis is thinning of the bones, which increases your risk of fractures. Like high cholesterol increases your risk of heart attacks. You don't feel thinning of the bones, but you feel the fractures and you don't feel high cholesterol. So that's the way I explain it.
So what are the major risk factors for osteoporosis?
So we like to think of white race, female gender, thin, early menopause, age, of course, tobacco and excess alcohol. But I think it's important to recognize that osteoporosis occurs in all genders and races.
Okay. What are some specific things like, let's say we all know that based on guidelines, we have to screen in women at a certain age and perhaps even men after a certain age, we can talk about that. But what else is there, other than just the age related, they're coming to you for primary care, but who else should you suspect?
So I think we'll talk about this later, but people who have risk factors or additional risk factors or diseases or medications associated with osteoporosis obviously need to be screened, and that's kind of a different set of people.
Okay, all right. Does it, sometimes our patients, they ignore this, they don't want to get screened, even though we are telling them multiple times. So what are some of the consequences of not getting screened and eventually having some consequence of osteoporosis? So how do we convince our patients?
So osteoporotic fractures are associated with pain, decreased quality of life, loss of independence, and increased mortality. For example, in Wisconsin, hip fractures associated with a 30% one-year mortality.
That's very high.
But more important to many elderly patients is loss of independence or the risk of going to a nursing home. In my discussions with older patients, I find it's not uncommon for the fear of ending up in a nursing home to be more compelling reason to manage osteoporosis than the fear of death.
Yeah, that can be pretty scary. I wanted to bring up some other thing that will come up many times that we'll discuss in our future episodes, is to clarifying the term fragility fracture.
So fragility fracture, its use is controversial. It tended to imply a fracture that occurred from standing height or less, or without trauma. But many patients will say, well, I fell, the floor was hard, it was only a thin rug. Anybody would have fractured. So a lot of people are now kind of moving away and just saying fracture. And so most people would advise evaluating a patient with a fracture after the age of 50. I have a slightly different kind of interpretation. I would divide fractures into high energy and everything else.
Okay.
So high energy would be you fell off the roof.
Okay.
You were in a high-speed car accident. I think that, that tells you something. But everything else, I think in older people above the age of 50 should be considered as possibly an osteoporotic fracture and recommend evaluation.
Okay. One other thing is that, toe fractures are very common. And, when I'm either doing an evaluation or going through fracts or something, where does the toe fracture fit in this whole?
Count it.
On it, just.
It's not an osteoporotic.
Fracture. Yeah.
Fingers,
they are
toes,
walking and stubbing their toe.
Fingers, toes, skull. Yeah.
Okay. All right. So I think these are the basics of osteoporosis, and lay a nice foundation into much more in-depth discussion that will happen in the next episode. Thank you, Joe, for this, really laying this groundwork. So, for our episode, for our listeners, please join us next time as we discuss secondary osteoporosis, about other contributing causes. If you like this episode, please subscribe, share, and spread the word to your colleagues. See you next time.
Thanks, Vidya.
Thank you.